Good morning, everyone, and thank you for joining us. Our webinar today is the integration of opioid use, overdose, and suicide, and this is the second webinar in this series. Our speakers today are Amy Bonnert and Mark Elgin, both from the Department of Veterans Affairs Center for Clinical Management Research and University of Michigan Department of Psychiatry. Our hosts today are the Great Lakes ATTC, the Great Lakes MHTTC, the Central East ATTC, the Central East MHTTC, and of course SAMHSA. Both the Great Lakes ATTC and the Central ATTC and MHTTCs are funded by SAMHSA. These are the grants that we're funded under. And the presentation today was prepared by the Great Lakes TTCs and is all of the information and opinions expressed are those of the presenters. Our webinar format today will be that the webinar is recorded and will be available for viewing along with the PowerPoint slides on our Great Lakes PTTC YouTube channel and our PTTC website. Today's audio will be broadcast through your computer speakers, so please make sure your speakers are turned up and on. There is no call-in number available. If you have questions, please use the chat box underneath for any questions or comments, and a Q&A session will be held at the end of the presentation. And I apologize, the PowerPoint slides will be on the ATTC and MHTTC websites. Our speakers today are Amy Bonnert and Mark Elgin. Amy is an associate professor in the Departments of Anesthesiology and Psychiatry at the University of Michigan and also a mental health services researcher with the Department of Veterans Affairs and for clinical management research. She obtained a PhD in public health from Johns Hopkins Bloomberg School of Public Health and completed a postdoctorate fellowship with the VA. She has led a number of federally funded projects related to addiction, overdose prevention, suicide, and prescription drug use. Mark Elgin is a clinical psychologist, a research career scientist with the VA Center for Clinical Management Research in Ann Arbor, and a professor in the Department of Psychiatry at the University of Michigan. He is also the director of the University of Michigan Addiction Treatment Services. And much of his current work is focused on methods to improve treatment outcomes in individuals with substantial substance use disorder, as well as strategies to decrease the likelihood of suicide in high-risk individuals. His research is currently funded by the Department of Veterans Affairs, the Department of Defense, and the National Institutes of Health. I'm going to turn this over to Amy.
Great, thank you very much. I think, great, I see my slides working now. We appreciate the opportunity to present to this venue. It's really wonderful that people are interested in this topic. It's something we both care about a lot. I'm going to do the first half of the talk, and then Mark will do the second half, and we will aim to be about 35 to 45 minutes to give plenty of time for questions at the end, and hopefully you can stick on that long, so feel free to put questions in the question box, and we will try and get to all of them at the end. In terms of acknowledgments and disclosures, some of the research we'll talk about will be stuff that other people have published that we've been thinking about, that's on our mind, that we feel like it's important to know about. But a couple of the projects we'll talk about specifically will be data analysis we've done, which was largely funded by VA Central Office. But in terms of any kind of disclosures, we have funding from the VA Research Service, the CDC, SAMHSA, NIDA, I think DOD, which somehow didn't make the list here. I apologize for that. Given that some of our funding is from VA Central Office, it's important to note that these are our opinions and not necessarily those of VA leadership. Do you want to mention your other COI or not related to this? Sorry.
I don't think
it's fine.
Yeah, I think it's not related.
Okay. So I thought this was a good way to start talking about why we're looking at overdose and suicide together. So this chart shows the relative change from year to year in the rate of death from these common causes of death in the United States. And this is all population. As you can see, for the majority of some of the most predominant causes, like cancer, which is the yellow line there, heart disease, there's been steady, if not slightly downward trends in the number of deaths, probably largely accountable to improvements in healthcare. However, overdose and suicide really stand apart from all of the rest in terms of having increased deaths in this, what we could look at here for a 10-year period. There's been a lot of attention paid to unintentional overdose as an increasing, often called an epidemic in the United States because of these sharp increases, but it's also important to note that suicide has been going up fairly steadily as well. So I think that leads to a lot of questions of why are these two different from the others, and might there be some common shared causes between the two. So we're going to talk about that today quite a bit, and specifically some of the issues around pain, mental health, and opioid use that probably underlie both problems. We did a review paper that came out a little under a year ago on this topic of opioid use, overdose, and suicide. And this table here is from that paper where we summarized the changes in rates in suicide and overdose on a year-by-year basis, but separated out among the suicide those that were intentional overdoses, and also look cumulatively of those two causes together, which is not often done, but probably an important way to think about doing surveillance and looking at the impact of any kind of prevention programs that are implemented because of how related these two are, which we'll talk about a little bit more later. So some big points to note. The rate of unintentional overdose, if you look in 2017, is higher than suicide. So this is absolute numbers. The last slide was relative change. But actually, overdose went from being a much less common cause of death than suicide in 2000 to actually surpassing it by a little bit as a rate by 2017. You can see that from those orange boxes there that the majority of unintentional overdoses, about I think 66%, were attributed to opiates in 2017, whereas a very small percent of suicides are directly attributed to an overdose by opiates as the mechanism. However, there's still overall about 40% of all suicide and overdose deaths, and that's suicide by any mechanism, are related to opiate use, including if not necessarily overdoses, but opiates where they were contributing to death and a suicide. So it's opiate use, I think, is one thing that is a particularly important focus when you're talking about overdose and suicide together, and we're going to talk about that quite a bit through the other studies. So I'm going to start with this idea of what are the potentially shared common causes between the two, so that we can then talk about some specific studies. And what I will focus on will first be societal level drivers. I'll talk some about where this data is coming from and how that makes it actually difficult in many cases to know whether a death is a suicide or an unintentional overdose. And then we're going to talk about individual risk and specifically around opiate prescribing history and how that may drive both suicide and unintentional overdose. So I'll start then again with the societal level causes. The two potentially competing theories that have been put out there for what forces are at play at a societal level that are driving these increases are sometimes conceptualized as supply and demand. So supply meaning more and more opiates were out in the community, and demand meaning that people, for various reasons, and often this is termed deaths of despair, there was more mental health problems and people were looking to opiates and other substances to cope more than had been in the past. So I'm going to talk a little bit more about each of those and cover a couple studies that give some evidence for each. So for the supply theory, the idea being that opiates were prescribed a lot more, and this is probably not new to anyone, but this is some data that has been put out by the DEA showing that the amount of opiates prescribed sharply increased from 1999 on. It's been somewhat stable, declining slightly in the last couple years, but actually, for all the talk about the pendulum swinging back too hard, I think there's the potential that that's happening in individual cases, but we're still prescribing a lot, and our numbers still have definitely not returned to 1999 levels. I won't get into all the reasons for why that prescribing is increased, but people have definitely talked a lot about increased advertising for long-acting opioids, especially around OxyContin being released as being safe for around-the-clock use for people with chronic pain, whereas that was not a common practice before then. As the amount of opiates prescribing went up on a societal level, so did the number of opioid overdose deaths specifically attributed to prescription opioids in that time. So that's the blue line there. I think one of the better studies to come out getting at this question of how much of the overdose deaths were driven by supply was this Enver working paper that was released just last November. So, and I apologize, I'm going to show a couple different of these time series type graphs. So you can see for all of them, the x-axis is time, and then the y-axis here is the death per 100,000 people. And what this particular study did is it compared states that had what was essentially an early version of a prescription drug monitoring program, or a low-tech version, where to write a prescription for an opioid, you had to do it in a triplicate form, and then that was used to evaluate, presumably used at a state level, to look for any outliers in prescription and do what PDMPs do now in terms of being able to identify what might be some problematic prescribing, more on the prescriber end, less on the patient end, as PDMPs are sometimes, there's concern that they're being used for now. So this study compared the handful of states that had that policy, so that's what triplicate means there for the blue dotted lines, to some comparison states that did not have that policy. And you can see that the states with the policy actually started out with overdose rates that were a little bit higher, but after the policy started, the states that did not have this early version of a PDMP had a much faster takeoff in their overdose deaths than those that did not. What I didn't show here was that they validated as a step before this that the states with the triplicate programs had much less sharp increases in prescribing as well. Some of the interpretation of the study has focused around the fact that Purdue Pharmaceutical chose not to put as much resources towards advertising and marketing for OxyContin in the states with the triplicate program, and making implications about the causal effect, if you will, of that marketing and advertising. I think the more obvious inference here is just that the states where it was prescribed more had much higher takeoff and rates than those that didn't, and this provides a little bit more of control on some of the other factors and ways in which states are different, because these were evaluating at a program level. But of course, it's important to note that this study is, again, very much at a higher ecological state population level, and not at all looking at individual level supplier access to opiates. An interesting thing that this study did that was really unique is that they looked at overdose, but they looked at some of these other causes of death. And you can see suicide here, which we're particularly talking about today, but both suicide and alcohol-related liver diseases have been conceptualized as other deaths of despair that we'll talk about next as the competing hypothesis. You can see that, if anything, so this is a slightly different form of graph, how this, again, the x-axis is time, but this coefficient estimate is the ratio of the rate in the states with a triplet program is the numerator, the denominator is the rate in the states without a triplicate program. So a higher number would indicate that there was more of an increase and higher rates of death in the states with rather than without, which this does suggest that for suicide, potentially actually there was higher increases in suicide deaths in the states with these early PDMPs than without. Although when they adjusted for other things in those bottom line, the bottom graphs there, the positive effect went away. So what this suggests was, at least in terms of this study and this particular way of thinking about opiate supply, it did not have an effect at a population level on suicide deaths the way that it appears to have on unintentional overdoses. So I alluded to the idea a couple times here that the competing hypothesis is one of demand, often thought of as economic factors. So their names are escaping me. Deacon and Case are the two economists who received the Nobel Prize for putting together this idea, where they looked and saw that the mortality rates, and specifically within this age group of whites without a college degree, and I think this is actually most concentrated among men, have had increasing mortality, or probably a better way to put it is mortality, premature mortality at a younger age, compared to people in those same socioeconomic groups in a lot of European countries where there have been declines, again, probably in response to improvements in healthcare and things like that. So, their idea with this is that that a lot of jobs that in the past would have been where people in this socioeconomic group would work, things like car factory jobs, manufacturing. There's been a decline in the availability of those, so the economic fortunes in this group resulted in them being worse off than prior generations in that same economic group. You can see I'm probably wording that in a overly precise way, but I think it's important to acknowledge that this is a group that actually is still economically much better off than a lot of people who are non-white in the same age and gender group. So this study just came out about a week and a half ago, or actually I'm not even sure it's published yet. It's been posted online at JAMA Internal Medicine, where this is probably one of the better studies so far to look at this question of demand. And what they did is they found counties that had a auto manufacturer close and compared it to similar counties that also where a lot of the economy was driven by auto manufacturing, but where the factory did not close, and then centered the time so that they could compare all of these counties over time, and looked specifically at opiate overdose deaths. You can see from the bottom two, they looked at, from the right-hand two graphs, they looked at prescription opiates and essentially heroin, but also ends up containing fentanyl overdoses separately as well. What they found is an overall effect there. So the bottom left graph is a difference in difference. So this is like the other graphs where it's a ratio of the change in the counties that were affected by closure compared to the counties that were not affected by closure. And they did find a significant effect where those counties that had an auto plant closure had a greater increase in opiate overdose deaths than those counties that did not. They did some further analysis where they looked at this by gender, and it seems to be largely driven by changes that happened among men and not women. And again, they found in white men, they didn't have the power to look in other ethnic groups. And I think they also did not have the analysis power to look at things like suicide. So really just to focus on overdose death, but a really intriguing finding. But in general, there's been a lot less study that has looked at this idea of deaths of despair in a concrete way, really tying it to economic factors rather than looking at a change and hypothesizing that they're driven by economic factors. One other study related to this that I think highlights the way in which everything I've said in the last 10 minutes may not be true, and that these are actually not in competition with each other, but there's more of an interaction between the two, was this report put out a little over a year ago from HHS. And what intrigued me about this one is that they looked at different economic trends. So they have the poverty rate there and the unemployment rate on each one of these four figures, but looked at them in relation to both supply measures. So the top two graphs are measures of supply, and then also the death measures, or the outcomes we're most interested in, the drug overdose deaths and the opioid-related hospitalizations. This is, again, very much at a population level, very ecological, but what I think is interesting here is that there looks to be more of a connection between those economic factors and the supply directly, because those top two graphs seem to share a little bit more of a common shape, and the economic factors and the overdose deaths and the opioid-related hospitalizations actually seem much less correlated. So it may be much more complicated. This, we'll put forward the idea that maybe the demand, there's more opiate supplied to areas where there is more economic problems. Maybe the supply is actually a mediating factor between the economic problems and the overdose deaths. So definitely something where there's still a lot of unknown questions. I think generally people who look at this think that there's probably some degree to which both are true, and addressing both at a policy level is important, but really a lack of data that isn't, that looks at this at an individual level, which I think will be important for studies to do next. I see in the question box there's a question about what I'm going to talk about on this next slide, which is knowing whether a death is intentional or unintentional. So a lot of the data that drives these studies comes from the National Death Index, which is compiled by the CDC by getting death information from each state's vital statistics office. And that data comes from the death investigation data combined with coroner data, and then that's reviewed, and ICD-10 codes are used to identify specific underlying cause of death, and then these have multiple cause of death codes where you can attribute it to specific substances. So that's the source of the data. Obviously a lot happens that builds up to that, and there's a lot of variability in how that happens across states. It's obviously very difficult to, with an overdose death in particular, it can be very difficult to know whether or not it was intentional or unintentional. Obviously, when there's a suicide note, that makes it a lot clearer, but I think it's something only like a third of overdose deaths have clearly a suicide note. This has gotten better, but there's pretty big variability in how much resources states have to put towards toxicology testing, or even at a lower level than that specific counties have. So that means that quite a few of these deaths do not have any toxicology testing done. So there's quite a bit of missing data when it comes to the substances, which means that in many cases the opiate, like that first table I showed, the number of deaths attributed to opiates is probably an underestimate. There's also differences in the amount of resources put towards the investigation more generally. So I specifically used a picture from the Wire here because Baltimore is a really interesting case example where when it becomes clear that that an unnatural death is not a homicide, it tends to get a lot less resources, because if they're not investigating a murder, knowing whether or not it's a suicide or an unintentional overdose death has a lot less implications in terms of public safety. So they do not put nearly the same amount of resources, and the vast majority of overdose deaths in the state of Maryland, as a result, are actually considered undetermined overdose deaths, which is unique. They're unusual that way, but I think it's a good example for thinking about how difficult this is and why the data is a lot messier than we would like it to be. Another piece of that is that, so I just talked through all of that as if these were two knowable categories of it's a suicide or an intentional overdose death or an unintentional overdose death. But what we see in a lot of the data collection we do with people who have had prior overdose experiences is that it's a lot less, it's a lot more ambiguous than that. So we've done a couple studies. We did one with emergency room patients who had had a prior non-fatal overdose, and then have a paper that's under review now with patients who were in addiction treatment who had opioid use and a prior non-fatal overdose. In both of those cases, about half of their non-fatal overdoses, they either outright said was a suicide attempt, or they said that they were not sure, or gave an indication of a risk behavior that was not entirely free of any suicidal intent, correct? Right. So interestingly, the proportions within those groups vary between the two studies, but the overall proportion was about half in both. And actually, the number who said that they just didn't care about their risks was 44% in the people in addiction treatment. Similar to the studies we did, there was a paper that came out just last year that recruited patients who were hospitalized for an opioid use disorder, who had had a prior opioid non-fatal overdose. And while the assumption tends to be in that group that their overdoses were unintentional and a lot of the prevention efforts think about the way you would prevent it as if these were things that were due to risk behavior and not at all to mental health problems that might also need to be addressed. A third of people said that their most recent overdose was a 7 or higher when they were given a scale of 0 to 10 to rate how much suicidal suicidal intent they had at the time. So I think cumulatively there's not too much work in this area, but I think most people actually, when they think about it, find this to be somewhat of an intuitive idea, that intent may be more of a continuum rather than a clear, discrete category of a suicide attempt or not a suicide attempt. So I think for the next bit, I'm going to hand off to Mark to talk about a specific study we did in this area. And this will be where we transition to talking about individual level data rather than societal level.
Great. So yes, Amy's been talking a lot about historically, at a societal level, how did we get here? And I'm going to talk maybe a little more specifically about who is at risk and then what might be able to be done about it. So this figure here just highlights the green boxes of suicide and overdose risk. That's a lot of times where you start in examining these trends and in what you hear about the epidemic of opioid-related deaths. Upstream of that is obviously opioid use and opioid prescribing, but there are a number of other factors that are also upstream, including depression and pain, and those might have pathways through opioid use to the outcomes of suicide and overdose death, and they may also have their own direct pathways to those outcomes, and then through other variables. So it's complicated, and opioid use plays a role, but certainly not the only role. So just to give a specific example of that, I'm going to talk about some of the work we've done around opioid prescriptions and risk of suicide. So we've known since really the mid-90s that chronic pain is a reliable and strong risk factor for suicide. And this is true whether you're looking at suicidal, non-fatal suicide attempts or death by suicide. And even in studies that were sufficiently powered and had good enough measurement of other factors like depression, anxiety, other potential drivers of suicide risk, it still appears to be the case that pain comes out as a consistent risk factor for suicide. And so that then naturally leads to the question of, well, where do opioids come in? On one hand, there's been a lot of concern expressed among treatment providers and the pain treatment community that opioids are really a lifeline that helps people with chronic pain stay safe and actually could have a protective effect on suicide. So this slide is just a screenshot of a letter to the editor, a thought piece by the president of the American Academy of Pain Management, who in this article is really advocating for the idea that opioids are essential for people with pain and that are a big part of preventing suicide in that high-risk group. On the other end of the spectrum, you have over 50 years of research from the suicide prevention literature showing that there's a pretty consistent relationship between access to lethal means and risk of suicide. This dates back to work that was done around blister packing of medications in the UK, the use of coal ovens and the switch to less lethal types of heating and cooking in European countries, bridge barriers, other consistent findings that essentially the harder you make it for someone to make a suicide attempt, the less likely they are to make an attempt or die by suicide. And also, they don't typically, or most people don't typically identify another form of suicide attempt and die by another method. So in this case, we were kind of framing the two competing hypotheses, one that among people with pain, opioids could help keep them safe or lower their suicide risk. On the other end of the spectrum, because opioids in high doses can be lethal, in people with chronic pain, they might be at greater risk for suicide. And we looked at this in VA patients. This figure here captures our results. This is all VA patients with a chronic pain condition who were prescribed an opioid, and it just looks at the extent to which someone's risk for the outcome changes as the prescribed dose changes. So for this specific outcome, we're talking about suicide, so that's the red line, and the scaling makes it look not overly dramatic, but there's an over doubling of risk for suicide as you move from a lower dose of opioids to a higher dose. So this is a notable increase in risk of suicide, but we benchmarked it here against unintentional overdose as an outcome. And what you can see is unintentional overdose increases much more notably as opioid dosage goes up. One interesting factor in these set of analyses that doesn't fit either of the two hypotheses I initially stated very well is that when you look at how individuals in this sample are dying by suicide, they actually look pretty similar to other VA patients. So the vast majority of VA patients who die by suicide die by firearm-related suicide, and that was the case in chronic pain patients in general, as well as chronic pain patients with opioids. So they were increasing in their suicide risk as they received more opioids, but it didn't seem that was specifically due to opioid-related causes, at least not as captured in the death record, which has all the problems that Amy already pointed out. This slide pretty much captures that last point I made. So if you look here at the risk of suicide, these are just Cox proportional models looking at hazard ratios that we're kind of zooming in on here for the different dosages of opioids. And in the bottom row, you see that your risk of suicide by any mechanism is a little over twofold greater when you're at the high end of the opioid dose. And that's pretty similar to what you see for intentional overdose as an outcome. And these analyses controlled for a number of factors, and the associations remain. So just talking through this individual level risk, there hasn't been much work in this area. So I'm describing our paper, and there are only, I think that you could count on one hand the number of studies that have been done that really link these individual factors to either of the outcomes, but specifically suicide. And there are some strengths to this type of work. There are also notable limitations. The biggest is what's often called confounding by indication, and this means that people are prescribed opioids for a reason, so a higher dose could capture the impact of that dose on the outcome, but it could also capture more loading of that reason that they were prescribed in the first place. And so we tried to control for those things statistically, but you can't really take those effects fully off the table. Another important piece is we're talking about opioid doses here in a way that's somewhat constant, or at least doesn't capture significant reductions in opioid use. And I think there are a lot of treatment providers who have concerns that I personally agree are significant concerns about abrupt tapering and that not equaling high-quality care. And I think there are really unknown questions about what happens following an abrupt taper, both in terms of unintentional and intentional overdose. That said, we didn't see any indication of protective effect of opioids for suicide. So now to talk really briefly about prevention approaches. So, when you read about the opioid epidemic in the popular media, or when state policymakers talk about opioids, they often say, we need to do something. We need to, as a community, we're sick and tired of seeing these negative effects. We need to turn it around and make a change. And this table here is pulled from the review paper that Amy and I did last year. And I think part of our point is that, yes, we need to do something. We completely agree with that. But there are ways in which the choice of what to do might have different impact on different patient populations, as well as the different outcomes of suicide and overdose. And you might policymakers might be well served to try and map their specific problem onto kind of a table format to figure out which outcomes do they really want to change, and which patient groups do they believe they can have the most impact in changing. And I think what we were hoping to convey is that some of these intervention approaches may involve changing opioid prescribing, and I think a lot of those are already underway in large health systems. The VA has several of those underway where they're scaling back on their use of opioids, and a lot of states and health systems within states like Kaiser and Group Health in Washington have made changes and are changing the prescribing. But that's just part of the problem, and especially for settings where overdose and suicide might be driven in large part by individuals who've already developed an opioid use disorder, there are likely other additional initiatives that are needed to target those patient populations. And I'm going to just talk about a few examples here, and we're cherry picking results, or I'm cherry picking results here, but the goal is to convey that it's there's reason for hope, and even for these outcomes that can feel very difficult to address, we have evidence that there are ways of addressing risk. So the results here on the slide called counseling approaches capture risk of suicide. These are two studies that were done about 10 years apart using different forms of cognitive behavioral therapy for suicide prevention. And they were very well done studies. I think as someone who's a consumer of randomized trials of behavioral interventions, I think these are some of the best designed and implemented randomized trials you typically see of behavioral interventions. And in both studies, you see somewhat similar results, and that is that the rate of reattempt, these were both groups of individuals who had attempted once, was about half in the condition that got CBT for suicide prevention than it was in usual care. So even in very high-risk individuals, you can have effects. In our work, we're currently in year 7. It's a long-standing study, but wrapping up a study of individuals with drug or alcohol problems who had a prior suicide attempt, where we're using a very similar form of CBT to try and reduce suicidal behaviors. And I'm hoping that we'll be able to add to this literature and show that you can have these effects in individuals with drug or alcohol problems. This figure here is actually from Amy Bonnert's work, and it is results of a study they did in the emergency department to reduce overdose risk behaviors in individuals who showed up having an opioid and engaged in risky behaviors previously. And the point here is that a relatively brief intervention that was focused on education and some motivational interviewing around risky behaviors significantly reduced the risk of risky behaviors that could be linked to overdose in this high-risk group. So this is overdose specific, not suicide specific, but in that group you can, at least the preliminary results indicate you can help those individuals stay safer. And then, of course, there are the effects of medications. So obviously, you can reverse an overdose, and there are a lot of efforts underway to increase access to naloxone. And secondly, you can treat the underlying opioid use disorder in those who meet criteria and have an established opioid use disorder, and that, in theory, could reduce someone's risk of suicide and overdose. And so this slide indicates that you can, when you provide access to naloxone and expand access, you can see greater utilization of that as a strategy, and that can reduce the number of ED visits and treatment episodes that might be needed for an overdose. You sometimes hear from the community, oh, if we provide access to naloxone, patients are just going to use more recklessly. It won't really get at the core problem, but it does seem to have benefits that extend beyond a single overdose prevention and could bear out over time. And this is capturing the fact that medication-assisted therapy in and of itself has a positive effect on reducing risk of overall mortality. So this literature is best supported by methadone research, and their studies, the cohort study has been going on for close to 30 years or maybe even over 30 years now, and as well as other ways that people have looked at this question. And the consistent finding is that when individuals are provided with methadone or by extension opioid agonist treatment, they tend to have significantly lower risks of mortality. Unfortunately, the way those studies are designed, it's often hard to drill down to specific causes of mortality, but that's, I think, more consistently found around unintentional overdose. And I think there's a few studies, 2 or 3 studies, that indicate that could also be true for suicide. Another caveat is that most of this work was done with methadone. This is before other newer treatments like buprenorphine have become available. Methadone is a more risky medication, but also is delivered with a lot more infrastructure around it. So you could come up with a rationale for why the effects might be more pronounced in terms of reducing mortality in methadone, and you could also come up with competing explanations for why they might be less pronounced. And so I think as time goes on, we'll have more consistent findings to look to from the non-methadone MAT literature. So just to conclude here, there are a lot of controversies and areas requiring further study. I've already mentioned this as Amy previously, but we have a lot to learn about not just overall risk, but what happens at key points in time. What happens as people transition into treatment, transition out of treatment, remain on treatment versus exit treatment or be tapered on medications, and then also what happens related to the speed of tapering. And I think that's a key issue for future work. There are all the challenges around the classification of the outcomes we care about and the need for improved measurement of unintentional overdose as well as intentional overdose. And all of this work, it feels like you kind of have your head around it, and then there's a substantial change. And fentanyl is certainly one of those things that kind of throws everything you think you know about this topic area a little out of whack. So as we see the fentanyl being more widely used, I think there's a need to continue to even redo some of these foundational studies to see whether the results still hold or whether they have changed. But that said, there's still, I think, a lot of reason to believe that the increases we're seeing in overdose and suicide share many similar pathways. Things like poorly managed pain, disability, and access to opioids matter in understanding risk for both of these outcomes. And addressing overdose and suicide will not be simply handled through a single approach, but really require a multi-tiered approach that's targeted for the group that you're most interested in and is most at risk. And I think that's all we have here, and we can open up to questions.
It looks like the first, if it's okay if I jump in,
Yeah.
It looks like the first question we haven't answered there was about whether the medications, I was looking in the question box, the medications only work on opiates. I thought you, with your UMass director position, could talk about that. The medications for opioid use disorders.
Yes. So, opioid use disorders, I think, are unique from other substance use disorders. So, from a treatment perspective, many of the things that work for one substance use disorder work very well for another substance use disorder. So, cocaine and alcohol, a lot of the treatment approaches look similar. That is less the case when you start talking about medication treatments, where they often target a specific vulnerability to a medication, or excuse me, to a substance. And so for Suboxone and the medications for opioid use disorders, there is a general, I think the general finding is that they work best for decreasing opioid use, that individuals who enter treatment for and stay on medication-assisted therapy also decrease in general with their use of other substances like cocaine, cannabis, alcohol, but those don't drop as notably as does opioids. And a lot of looking at outcomes for those substances is driven by what are the policies of the clinic. Is the clinic tolerant to continued use of those substances, or do they eventually discontinue the patient?
Yeah, I think to add to that, something we see a lot in the community work we're doing is that it's important to recognize that continued use of other substances isn't a sign that that treatment is failing and needs to be stopped, but rather that the other substance use disorders may be present and need additional treatments that are aligned with that substance. I actually thought that question may be partly about naltrexone. So in terms of other substance use disorders, there's much less medication-based therapy in general, with the exception of naltrexone for alcohol use disorders, which is actually more established than its use for opioid use disorders, although it's FDA approved for both. Mostly working through the mechanism, for both of them, it's working through the mechanism of decreasing craving. Did you mention on the medications for opioid use disorders, you definitely talked about the fact that for the other medications other than methadone, it's less clear on what the impact on mortality is. There's some concern that there's actually a risk of increased overdose risk with naltrexone because it doesn't replace replace is the wrong word, but it's not an opiate, it's not a partial or full agonist. So there's some concern that people, if they do resume opiate use, are at much greater risk for an overdose.
With naltrexone on its own, not in combination.
Yeah, and it also has much worse adherence and initial uptake when it's been compared head-to-head in RCTs to Suboxone. Sorry, I think I'm turning away from the speaker, so I'll stop doing that. So the next question is, could you suggest any screening tools for substance use disorders?
So I think that depends on the setting. I think if you're in a primary care setting, there are, for alcohol use disorders, the Audit C is, I think, the easiest and best option. There have been efforts to develop drug-specific versions of the audit, and they don't perform all that well. It's a little challenging. The best question is, have you used another substance? And if someone has, they're generally much more likely. That's your most sensitive way to measure it. There is the assist, that the World Health Organization assist is what we often use. I think it's mostly user-friendly, and it's available free in PDF form online. So if you Google WHO Assist or World Health Organization Assist, you should be able to get the PDF manual for that. And I think that's a reasonable measure. That picks up both quantity and frequency, but also some of the problems that go along with what you think of as symptoms of a substance use disorder.
Yeah, I would just add that if this sounds like it was more of a broad population screening, but if you're talking about a screening tool that you would use among people who are being prescribed opioids, we like the current opioid misuse measure for that. You need something, I think the assist and things like that tend to not do a good job of picking up on potentially use problems because they specifically exclude use, or the wording is tricky for understanding what they mean if you're being prescribed a medication and potentially having a use disorder with it. So the next question there looks like it's about CBT versus usual care and the RCTs for CBT for suicide. And I think wanting to clarify that the comparison group was usual care.
Yes. So in both conditions, they got, those in the non-CBT condition got a little bit of case management, but for the most part, they were free to get treatment as usual, and they didn't really try and dictate what that was. Just to put a plug in for our own ongoing study of that, we have a control condition in our randomized trial that is intended to match the intensity of the CBT condition, just minus the CBT content. And I think one of the key scientific questions is whether it's the attention that matters or whether it's the specific intervention content, and that still needs to be kind of established over time.
Looks like the next question is about for patients who are getting medications for opioid use disorders, will there be a point where they no longer need that treatment, and what are the data on relapse? So the first part of that is tricky. There's definitely a lot of I think there's not been a lot of great longitudinal studies that would say, once you hit the 3-year mark, your chances of relapse if you stop are pretty low, so it's okay to try. I think most studies have, in some ways, actually the way that the efficacy for those medications, for buprenorphine in particular, has been established is by comparing a short-term protocol of it to a indefinite protocol of it. And what those studies have found is that the short-term protocol has much worse outcomes than the long-term. So I think what's known for sure is that your patients will likely have better outcomes if the treatment plan is for them to stay on it indefinitely, compared to a treatment plan to go off it after 2 months, 3 months, those types of protocols. I'm purposely not using the word, because obviously the outcomes are going to be different if a patient is adherent or not. So these were studies that compared different treatment plans, which is an important caveat. So I think that's an unanswered question, but there's plenty of data that patients often don't want to be on it for the rest of their lives. So I think it's an important question. I think most people would agree that if a patient is feeling like they're doing well and would like to try to stop, that working together to come up with a tapering plan with frequent check-ins on how it's going and a kind of low threshold to return to the prior level of treatment. I'm not a physician, so I don't want to be speaking out of turn, but I think that is generally the consensus for what's the most patient-centered way to handle that question. In general, the statistics on relapse are that it is much better than non-medication-based treatment, but still, like any chronic condition, having symptoms, and in this case symptoms being use, is a common and expected thing to happen after treatment has started. I'm having trouble, pulling up the numbers off the top of my head of how frequent it is, but.
I mean, I think in terms of Roger Weiss's study, I think that they found that the rates of treatment failure approached 85% as they moved into the taper.
Mm-hmm.
So the vast majority of people who get abstinence-based treatment who have an opioid use disorder do not have positive outcomes. And for medication-assisted therapy, you get back to that number pretty quickly as you taper, at least if you taper in the short-term
Mm-hmm.
sort of way.
Mm-hmm.
I want to say that the treatment failure rates were they were certainly significantly lower. I want to say they were kind of around half of that
Right.
in the medication-assisted therapy group. But
Where the plan is indefinite treatment.
where it was just
Yeah.
to keep them on treatment. But I'm pulling numbers from thin air, so that's always a risky thing to do.
Feel free to email us, because this is something that I'm happy to follow up with specific studies and numbers on and help find those. The next question is about, and I'm gonna give this one to you, whether marijuana use helps or hinders opioid use and addiction.
Yeah, so this is an excellent question, timely.
And I'm handing it to you because you've done a fair amount of research on medical cannabis use in Michigan in particular.
Yeah, we have a research study that wrapped up a year or two ago on adults who use medical cannabis for pain and how their cannabis use relates to their opioid use and misuse. And I think that the short answer to the question, does marijuana help or hinder opioid use? We don't have great data one way or the other in this case. I think I'd be cautious of anyone making, or skeptical of anyone making strong statements, either saying it's horrible or that it saves the day and it's the new panacea to address the problem. What we saw in medical cannabis patients is that as people with chronic pain started receiving and using medical cannabis in Michigan, they had a ton of problems when they showed up to a medical cannabis clinic. So that meant generally low functioning, high depression, high rates of PTSD, high rates of unemployment, high pain, and high rates of opioid misuse. And when they got medical cannabis, they started using medical cannabis very heavily, pretty much daily, and 80-some% of our sample, I think it was almost 90%, were using daily by the end of 2 years. And they still had, on average, all the problems they did when they came into the treatment. So very few people had their problems resolved, and very few people, did we see what I would say were kind of clear negative outcomes due to medical cannabis. So, in my mind, I think that patients who seek out medical cannabis, and these were early adopters of medical cannabis, so it may be a little different nowadays. But I think they're struggling. They're really desperate and looking for something to help. They embrace it enthusiastically, and 2 years later, they're still really struggling and looking for something to help. But now we're also really engaged in spending a lot of money and time on cannabis. So, I still think it could work. The type of design we had, not a randomized trial, so there's no way to attribute causality one way or the other, but at least you're not seeing signals that it's really turning things around and making it much better. So that was a little bit of a rant in general about medical cannabis. I think related to addiction, there are almost no well-controlled studies that look at it as a treatment for addiction. I think most treatment providers know from the literature on, let's say, smoking and addiction that in general the use of an additional substance tends to activate the same areas of the brain that the initial substance of abuse did, and tends to be a predictor of worse outcomes following treatment.
Great. I think we have time for one more question. We'll probably do it pretty quickly. and that there was a clarification with the marijuana one, but I think we hit on most of that other than the risk factors. Maybe I'll drop to the last one, which if I'm understanding